Mark, you're not off the hook. Thank you yet. We've got some great questions, all right?
All right.
And so I answered and addressed a few coming in. We have about 5 minutes or so for questions, and I apologize to folks who had excellent questions. We just had a flurry of them. The PTSD comment is very intriguing. It sounds like we're using opioids and benzos to treat existential suffering, not as much as the physical domains. So what are the other treatment options that have shown the best outcomes for those with PTSD? So how might once you identify it, trick one, trick two is what do we do in terms of management without benzos?
I would strongly recommend using what is called the PTSD PC screener. And the National Center for Traumatic Stress, or you could just Google that, and it's a 4-item screen. It's very useful. We use it in our clinic. It really highlights the issue where you thought it didn't exist. I would suggest that as the identification strategy. Treatment strategies, the best, most well-validated treatments for PTSD are psychological treatments, cognitive processing therapy. Trauma-focused therapies are good. Cognitive behavioral therapy for PTSD is also good. If you cannot access these evidence-based psychotherapies, there are treatment guidelines about medications. Benzodiazepines are not recommended. I mean, people love them. They love their Xanax. It will help them for about a week, and then it won't. SSRIs do help. There are some intriguing new treatments, particularly for the nightmare and hyperarousal symptoms of PTSD, often not tried before. Prazosin, the alpha blocker that had been earlier marketed for hypertension as mini-press, has been shown to be quite effective in combat trauma, and now even more and more populations. That's a useful tool as an adjunct to treatment of PTSD, not a treatment sufficient all by itself, but helpful.
Okay, another good question. Thanks, Mark. That was very helpful. I'm going to combine two questions because it's a common theme. One is, people are filling out these reported questionnaires. How can we trust them? How do we establish a frame of mind that we don't consider our patients to be drug-seeking and in the highest risk groups based on a questionnaire? And will this ability to follow patients over time allow us to risk stratify more effectively?
So it is tough when you're inheriting a patient. And remember, what I like to tell my trainees is that when you're prescribing, you're in control, but you're also responsible for what happens. So if you don't feel like you have gotten enough information about a patient, their previous prescribing history, their substance abuse history, don't prescribe until you are comfortable that you have gotten enough information. Opioid withdrawal is uncomfortable. It is not fatal. I mean, if somebody's on benzodiazepines too, it can be riskier, but if you've not prescribed to a patient, it's not your problem. You need to be clear. We check on people. You know, before we prescribe, we get a urine tox screen. If you don't look, you don't know. We look at the prescription drug monitoring program. We require contact with previous prescriber. We love to talk to third parties like family members. All of those sources of information are going to help you check on a patient who you don't know and don't know whether you can trust. There's no 100% effective strategy in this regard, and you may have to do a trial prescription, but do not feel like you are obligated to prescribe or continue prescribing if you feel like you have not been honest with, the patient has not been honest with you, or you don't have a full enough story.
So how good are we as clinicians? As you know, I started my career in primary care, and I really thought I could tell my patients. I used to call it the sniff test. This smells like a safe case. How reliable is the sniff test for primary care providers following people over time? What measures of success? Coin toss, better? Are there
I don't know data
flags
on this specifically. I do actually value long-term acquaintance with patients. I do think that people who have an enduring therapeutic relationship with their patient are in a different position than an ER doc. I think you're really in a high-risk situation where you have to treat somebody you've never seen before. Somebody who you have seen and will continue to see is somebody who I think, A, is probably at low risk to start with, and the fact that you're going to have continued visits and you're going to be able to see behavior and get more information. That does, I think, lower the problems. But just by the way that you were phrasing it, sniff test, you can be duped. It's not 100%. I think you always need to be ready to be surprised.
Yeah, well, I've been humbled many times.
Yeah.
I'm wondering if I'm in the minority, or I think it probably represents the reality of the relationship with folks who have a secondary agenda. That's difficult to bring out.